Assalamualaikum and hi. We are from Group 7, which have Muhammad Fadil bin Ahmad, Muhammad Hafiz bin Zaini, and I am Muhammad Hafizul bin Muhammad Noor. Today we are going to present on Chapter 18 about symptoms, signs, and abnormal clinical and laboratory findings not elsewhere classified. The code is from R00 to R99. Next, we go to the first presenter, which is Muhammad Fadil.
Alright, my name is Muhammad Ahmad. I will explain about everything we need to know about this code. Firstly, the use of the symptom codes. How these codes want to be used. When a final diagnosis or the indication not be confirmed by the provider, the code that describe the symptom and also indication are acceptable for reporting purpose. Next is about when the symptom codes present with a definitive diagnosis codes. For the symptom codes, the definitive diagnosis code should be sequenced. And lastly, when the combination codes that include with a symptom. When using a combination code, an additional code should not be assigned for these symptoms. Next, we go into the condition that permit the assignment of code R00 until R99. Firstly, the body system categorized symptom and sign are from the R00 until R69. For example, R00 until R09 is the category for circulatory and also respiratory system. Next, another example is R10 until R19 is about the digestive system and also abdomen. Next, they categorize for abnormal finding and also remaining categories without diagnosis are categorized as follow: R70 until R99. For example, R97 is about the abnormal tumors markers. And lastly, another example is R99 that is about ill-defined and unknown cause.
Thank you, Muhammad Fadil. Assalamualaikum. My name is Muhammad Hafizul bin Muhammad Noor. Next, we move to the repeated faults. In this part, there are two codes, which is first code is R29.6. This code is when a patient has recently fallen and the reason for the fall is being investigated. Number two code is Z91.81. This code is about history of falling, is for use when a patient has fallen in the past and is at risk for future falls. These two codes may assign together when it's appropriate. Okay, now we go to the coma scale. The code is R40.2. It can be used in conjunction with traumatic brain injury codes. The coma scale codes should be sequenced after the diagnosis codes. One from each subcategory are needed to complete the scale. The seventh character indicates when the scale was recorded and should match for all three codes. Assign code R40.24, the Glasgow Coma Scale total score when only the total score is documented in the medical record and not individual scores. Do not report codes for individual or total Glasgow Coma Scale scores for a patient with a medically induced coma scale or a sedated patient. Next, we go to the Muhammad Hafiz as a next presenter. Thank you.
Okay, the next one is SIRS due to the non-infectious process. The systematic inflammatory response syndrome, or known as SIRS, can develop as a result of a certain non-infectious disease process, such as trauma and malignant neoplasm. When SIRS is documented with a non-infectious condition and subsequent infection is documented, the code for the underlying condition such as an injury should be assigned, followed by code R69.10 Systematic Inflammatory Response Syndromes SIRS of non-infectious organ without acute organ dysfunction, or code R69.11, which is Systematic Inflammatory Response Syndromes SIRS of non-infectious organ with acute organ dysfunction. The next part is that NOS, not otherwise specified. Code R99, which is ill-defined and unknown cause of mortality, is only for use in the very limited circumstances when a patient who has already died is brought into an emergency department or other healthcare facility and is pronounced dead upon arrival. However, it does not represent the discharge disposition of that. Finally, the last subtopic, which is NIHSS stroke scale. The NIH stroke scale, which is known as NIHSS, codes from R29.7 actually can be used in conjunction with acute stroke code, which is I63, to identify the patient neurological status and the severity of the stroke. The stroke scale codes should be sequenced after the acute stroke diagnosis codes. At a minimum, report the initial score documented. If desired, a facility may choose to capture multiple stroke scale scores.